Hello, and thank you for joining us for this specialized webinar, which is part of our series for the Dimensions Tobacco-Free Priority Population Masterclass. The title of today's webinar is Adverse Childhood Experiences and Trauma-Informed Care. We'll be discussing why trauma and early trauma are important topics for consideration when thinking about comprehensive tobacco treatment, particularly for priority populations. I'm Christine Garver-Apgar, and I'm an assistant professor of psychiatry at the University of Colorado Anschutz Medical Campus. I'm also the research and evaluation director at the Behavioral Health and Wellness Program. And I'm joined today by my colleague, Teresa Mesher, who is a research associate at the Behavioral Health and Wellness Program. Our goals for the webinar today are to first articulate a trauma-informed theory of health behavior and health behavior change. We're going to summarize a few scientific findings related specifically to early adversity, addiction, and tobacco use disorder. We will then describe general principles of trauma-informed care, and then finally we'll discuss implications of this understanding for tobacco treatment services within health disparity populations. And before we jump in, I'd like to just acknowledge that it may not be entirely obvious why experiences of trauma and early adversity are important topics to address when we're considering tobacco treatment services for health disparity populations. So I'd like for you to consider the prevalence of adverse childhood experiences in just a few of the populations that we have been focusing on throughout this masterclass. And I'm going to just talk a little bit about data that were taken from the 2011 through 2014 Behavioral Risk Factor Surveillance System. This was a publication in 2018 from data that was taken across 23 states. And they found that significantly higher childhood adversity exposures were reported by participants who identified as Black, Hispanic, or multiracial, those with less than a high school education, people with incomes of less than $15,000 per year, people who were unemployed or were unable to work, and those who identified as gay, lesbian, or bisexual. And other data supports a lot of these findings. For example, individuals with lower income, those who, as well as those who have mental illness in adulthood, LGBTQ individuals experience greater adversity during childhood. But I also want to note that not all studies find increased ACE exposure in some of these demographics. For example, some studies do not find increased ACE exposure in African Americans and Latinx individuals. So findings vary a little bit. But in addition to adverse childhood experiences, these populations noted here are more likely to have experienced historical trauma at the population level, and they're more likely to have experienced organizational and societal trauma. And so providers must account for this history to avoid replicating traumatic environments during treatment, including treatment for tobacco. We'll talk a little bit more about this and why it's important at the end of the presentation when we talk about implications for tobacco treatment. Much of the rest of this presentation will describe why these experiences increase vulnerability for nicotine addiction and tobacco use disorder. But we thought it was important to be explicit about why early adversity and trauma increase health disparities related to tobacco use and treatment within these populations before we go forward. So we know that trauma exposure is a critical risk factor for the development of harmful health behaviors and poor health outcomes. And we know that not all communities experience trauma equally. And a recent paper sought to provide an explicit theoretical framework to help explain the mechanisms driving the relationships between trauma exposure and individual health behavior change that I thought was helpful for our discussion going forward today. And essentially, the theory is rooted in the understanding that trauma exposure leads to elevated physiological stress responses, and that individuals make their best effort to address these responses with limited resources. And what that means is that individuals have to trade off how they prioritize these limited resources. And so they will often prioritize more immediate threats and stressors over long-term health behaviors, which of course are often the focus of health behavior change interventions. And so it really helps us to situate the health disparities that we see within this theory, and understanding why some populations can tend to have a harder time with health behavior change and health behavior change interventions, and why the health disparities are so pervasive and persistent. So what kinds of trauma are we talking about that impact health behaviors? Well, some trauma can be thought of as individual or interpersonal, and this would include things like experiencing physical or emotional abuse from a parent or a caregiver as a child. It could be experiencing domestic violence, either as an adult or in the home as a child. Much of the research looking at impacts of trauma on adult health behaviors has focused on this type of trauma. And so we will dive a little deeper in this presentation on this type of trauma as well. And as we saw a couple of slides ago, some populations do experience more of these types of trauma than others, which serves to increase health disparities. But there are other types of traumas that we need to be considering that also help us to consider health disparities through a wider lens. Social networks and organizations shape the environments in which individuals are exposed to trauma. State and federal laws and policies shape environments in ways that expose some populations to additional trauma burdens. So, for example, policies preventing people with substance use convictions from accessing federal housing or income assistance reinforces poverty and homelessness. And of course, we know those policies disproportionately impact some populations more than others. And then finally, some groups are subject to additional identity-specific forms of historical trauma. But the burden of these harms is passed down from generation to generation. Today, we know, of course, the health of Black communities can't be separated from our history of enslavement, the failures of Reconstruction, racist housing policies, the war on drug policies, and all of that has led to mass incarceration. So all of the trauma constructs listed here, I want to note, along with the severity of PTSD symptoms, have been linked with poor tobacco cessation outcomes. So this is really a broad view of trauma. And I'm going to turn now to a more detailed discussion about one of these forms of trauma as it relates to nicotine addiction and tobacco use. And that is the individual and interpersonal trauma experienced during early childhood, also known as adverse childhood experiences, or ACEs. But before I share information about adverse childhood experiences, I want to very briefly review the pathways by which nicotine addiction is passed down within families, because this will help give a little context to some of these findings. Okay, genetics. So there is a genetic component to addiction, including nicotine addiction. There's genetic variation that makes some people more vulnerable to all addictions. This would include food addictions, gambling, drug addictions. And then there are some genetic variations that make some people more vulnerable to nicotine addictions specifically. So this would include variations in nicotine receptor sensitivity, for example, or how fast or slow a person metabolizes nicotine. That has been shown to relate to the severity of nicotine addiction. And then there is variation in genetic traits that are associated with substance abuse more broadly, like personality traits, things like risk-taking or impulsivity or behavioral disinhibition. These are, of course, all of the things that we can't change. And then, of course, there are environmental influences. Parents and caregivers role model health behaviors. We know that children who are exposed to family tobacco use have a more positive view of smoking, and they tend to underestimate the harms that come from smoking. They also have a more favorable view of people who smoke. And of course, they're more likely to become tobacco users themselves. And then there are developmental influences that happen when a baby is exposed to nicotine in utero. Some evidence suggests that babies' brains are primed for nicotine exposure during development, such that they're more likely to become addicted to nicotine as adolescents. So their brains develop differently. And then there's something called epigenetics. This is a more recent idea that has been having a lot of research around it over the last decade or so. And it's the idea that experiences that we have can actually alter the expression of our DNA in ways that are inherited by future generations. So in other words, our experiences are actually transmitted to future generations along with our DNA. And this really gets at the heart of why it's so important to interrupt this intergenerational cycle of poor health and disease that seem to persist in some families. And there's evidence for this, not just with addiction, but really with all different aspects of health, obesity and diabetes, for example. And it also explains why a focus on adverse childhood experiences is so important. When you consider that early experiences of adversity may change the expression of genes related to addiction for future generations, we can see how important a topic this is for researchers and healthcare providers to begin to consider. The American Academy of Pediatrics has said in a policy statement that protecting young children from adversity is a promising science-based strategy to address many of the most persistent and costly problems facing contemporary society, including limited educational achievement, diminished economic productivity, criminality, and disparities in health. This policy statement really reflects a paradigm shift in the medical community's approach to health and disease, which has been taking place over the last few decades. Researchers and practitioners are beginning to recognize that a truly diverse array of health problems, including chronic disease, mental illness, addiction, cognitive challenges, and socio-emotional difficulties, can all be thought of as having their roots in early childhood development. So many of you have likely heard of the Adverse Childhood Experiences Study. This landmark study of over 17,000 adults really catalyzed a significant shift in pediatric practice, and it also launched a new research paradigm known as the developmental origins of health and disease. When the Adverse Childhood Experiences Study was published in 1998, at that time, psychologists and sociologists and medical investigators had really only begun to examine long-term impacts of child abuse. And at that time, typically they were looking at childhood sexual abuse on adolescent health and adult mental health. Up until this point, studies had not really examined associations between childhood abuse and medical problems, and nor had they examined other sources of childhood adversity that are likely to co-occur with various forms of childhood abuse, things like parental substance abuse or domestic violence or criminal activity in the home. And without measuring these other types of adversity, negative outcomes couldn't be attributed solely to one single type of childhood trauma, and effects of cumulative exposure to multiple forms of adversity weren't really being assessed. So the ACE study set out to examine the long-term impact of abuse and household dysfunction during childhood on several different types of outcomes in adults. So the study examined early childhood exposure to 7 different forms of adversity listed here on the slide: psychological abuse, physical abuse, and sexual abuse, and then substance abuse in the household, mental illness in the household, domestic violence, and criminal behavior in the household. And what the study found was that these experiences occur regularly across all races, economic classes, and geographic regions. However, there was a much higher prevalence of ACEs for people living in poverty. And as I noted earlier, more research has now found disparities in ACE exposure that extend beyond just income. One of the things that the study found that surprised the researchers is just how common these experiences were. More than half of all respondents reported experiencing at least one of these categories of childhood adversity, and over a quarter reported having at least 2 categories. And considering that the entire study population was comprised of people who were insured by Kaiser, it was already a non-representative sample in many respects, since those who have access to private insurance are likely different in many ways from those who don't. And so this was quite surprising, I think, to the researchers and the medical community at the time that this study came out. So the ACE study found impacts across all kinds of health indicators, everything from cardiac events, obesity and diabetes, cancer, suicide, depression, alcohol use, sexually transmitted diseases. Pretty much everything that the researchers looked at were influenced by ACE exposures. But I want to show you data related to smoking from this study. And I think this slide was briefly presented during the masterclass, but I'll just review it here. A separate study based on the same data found that people who reported more than 4 ACEs compared to people who reported none were over 5 times more likely to start smoking early. And we know the timing of smoking initiation in the life course predicts the severity of the disorder. The earlier a person starts using nicotine, the more likely it is that they will continue to use the substance throughout their lives. They were also more than 3 times as likely to report ever having smoked in their lifetimes. They were over twice as likely to report being a current smoker, and they were almost 3 times as likely to report being a heavy smoker. Now, since that time, a whole host of research has delved more deeply into these relationships between early adversity and nicotine addiction and cessation outcomes. We now know that early adversity increases people's risk for addiction vulnerability. People exposed to early adversity aren't just more likely to try a cigarette. It impacts persistence of nicotine addiction. It impacts a person's the difficulty that they have in quitting. It impacts the extent to which they crave nicotine during their quit attempts. And really, it impacts the entire course of the disorder. It's also the case that experiencing early adversity predicts diagnoses of nicotine addiction in both sexes, but the relationship is actually twice as strong in women as it is in men. And we're going to have much more to say about treatment in just a few minutes. But I'll note here that this sex difference has some important treatment implications as well. Research has found that in women, but not men, attachment anxiety is associated with smoking, and that this attachment anxiety partly accounts for the association between adverse childhood experiences and smoking in women. Attachment anxiety is a form of attachment insecurity that's associated with adverse childhood experiences. It's essentially the fear of being abandoned. The treatment implication here is that for women who are trying to quit, who disclose early adversity, and who demonstrate subsequent attachment anxiety, a tailored treatment strategy might be to supplement standard care with increased social support. And really, that is not a bad idea for all women trying to quit, because we know that women particularly benefit from additional social support when trying to quit smoking. But this may be particularly true of women who have experienced trauma. So the question that I want to turn to is why? How is it that we go from experiencing early adversity to addiction? What are the pathways that lead from one to the other? Most studies show that when children experience chronic stress during early development, they grow up having more blunted or diminished cortisol responses to stress later. So what does that do? Well, it changes how the brain responds to different things that make substance use more likely. And I'll give kind of a few examples here. So decreased cortisol release might alter reward pathways in the brain so that people have a reduced feeling of reward. We know that substances like nicotine stimulate dopamine activity in the brain. That increases feelings of reward. And so seeking substances for some people may be seen as self-medicating behaviors when those reward pathways are diminished. Relationships between smoking and blunted dopamine activity actually work in both directions. Smoking can further cause blunting of reward sensitivity. So it sort of becomes a vicious cycle. Smoking, reduced stress reactivity is also likely to diminish internal cues associated with danger when an individual confronts risky choices. And that can contribute to increased risk-taking in daily life. Experiencing early adversity can also lead to unstable emotion regulation and a tendency toward negative emotions. And that can also contribute to behaviors like substance abuse or substance use that seek to alleviate those negative emotions. And these things may all contribute to a more impulsive behavioral style and a greater willingness to take risks with a reduced aversion to the potentially negative consequences. So over a period of years, these behavioral tendencies may contribute to a risk for addiction and poor health behaviors more generally. And then finally, the association between early maltreatment and alcohol or drug use manifests at a really young age. Exposure to early stress shifts that initiation of drug use to younger and younger ages. And so as a result, a substantial percentage of abuse victims become exposed during a really vulnerable developmental window when we know that substance use is more likely to lead to future abuse and dependence. So this was just a little bit of a deep dive into what's actually going on in the brain and why these experiences of trauma and early adversity might actually lead to increased nicotine addiction and poor cessation outcomes. And so now what I would like to do is hand it over to my colleague, Teresa, who will describe trauma-informed care and discuss implications of understanding trauma-informed care for tobacco treatment services, particularly within health disparity populations.
Thanks, Christine. Now that you have an advanced understanding of early adversity and its effects on tobacco use and cessation, particularly among health disparity populations, I want to introduce the framework of trauma-informed care and how it can be helpful in tobacco cessation treatments. First, I want to start with a comprehensive definition of trauma-informed care before explaining the details of the framework. Trauma-informed care is defined by the Substance Use and Mental Health Services Association, or SAMHSA, as the understanding that how trauma is addressed or treatments are deployed contributes to outcomes for trauma survivors, the people receiving services, and the individuals staffing the systems, and is essential to the context of care. SAMHSA defines 4 assumptions of trauma-informed care and says that a program, organization, or system that is trauma-informed realizes the widespread impact of trauma and understands potential paths for recovery, recognizes the signs and symptoms of trauma in clients, families, staff, and others involved with the system, and responds by fully integrating knowledge about trauma into their policies, procedures, and practices, and seeks to actively resist re-traumatization. This means that all persons within the organization must possess a basic understanding of trauma, its effects on the people and communities that they serve, and understand that trauma is widespread. It affects individuals as well as entire communities or populations, as Christine talked about earlier. In addition, an organization should know that people's behaviors can be seen as survival coping methods based on either current or past experiences, and that trauma is linked to mental health and substance use. Therefore, an organization must realize that trauma can be a barrier to successful treatment of mental health and substance use disorders. Organizations must also be able to recognize the signs of trauma. Some examples of signs of trauma include age, gender identity, and triggering settings or environments. A trauma-informed organization then responds by instituting policies and changes that create an environment that considers traumatic experiences of the people they serve. This includes changing language and behavior to be more sensitive, trusting, and inclusive, as well as creating a culture based on resilience, recovery, and healing from trauma. Finally, organizations are conscious about the environment and culture they exude to people they serve and intentionally evaluate the organization to remove toxic policies, methods, and behaviors that may trigger and/or re-traumatize people they serve. By abiding by these 4 assumptions, or the 4 R's, an organization can move toward the progress of implementing a trauma-informed mindset to better serve their community. In addition to the 4 R's, SAMHSA also outlines 6 generalizable principles of trauma-informed care, and adherence to these principles is essential to maintain a trauma-informed approach. First, all persons in an organization must ensure physical and psychological safety for all the people they serve. This includes understanding the unique safety needs for health disparity populations, such as LGBTQ+, Asian American, and Latinx persons. The physical environment must be safe without triggers, and organization representatives must interact with patients in an inclusive, safe manner. Second, an organization that establishes its mission, policies, and operations with transparency work towards the goal of fostering trusting relationships with the people it serves. And these trusting relationships are really important to the idea of trauma-informed care. A focus on peer support also helps build the trust in the organization, while also establishing feelings of safety and promoting healing and recovery. Peers are persons who have similar life experiences as the people you serve and are there to connect with patients and help one another along. Collaboration and mutuality recognizes that the power must be shared among all members and levels in the organization, from maintenance staff to the directors. By creating a collaborative culture, all organization staff are empowered to help patients since everyone has a role in providing trauma-informed care. Empowering both staff and patients gives a sense of autonomy. Staff are seen as facilitators rather than controllers, and they give patients a voice and a choice in their treatment and their recovery plan. The organization trusts and supports staff in an effort to empower them to do their work well and makes them feel safe, just as the organization does for the people they serve. And finally, cultural, historical, and gender issues must be considered. An organization must be aware of past cultural stereotypes and move past them while also providing gender responsive services and recognizing and addressing historical traumas. Understanding cultural connections can bolster healing as well. In addition, population-specific needs, including racial, ethnic, and cultural, must be considered when developing and implementing organizational policies, protocols, and processes. So now that we've gone over trauma-informed care in detail, I want to remind you of that motivational interviewing is also a form of trauma-informed care, and it's a great place to start in developing your own approach. So up until now, we have discussed trauma, ACEs, and trauma-informed care in great detail. And the remainder of this webinar will now focus on how to combine all of those ideas to treat tobacco use in health disparity populations. And I'll end with a brief example of a trauma-informed care plan in a health disparity population. So now, as we move into talking about how to incorporate a trauma-informed care approach for tobacco treatment of health disparity populations, I wanted to revisit the trauma-informed theory of health behavior that Christine spoke about earlier. As a reminder, the theory is rooted in the understanding that trauma exposure leads to elevated stress responses, and that individuals make their best effort to address these responses with limited resources. This means that individuals will often prioritize more immediate threats and stressors over long-term health behaviors, which are often the focus of health behavior change interventions. So we aim to intervene with a trauma-informed care approach after stress responses are established to give patients the tools that they need to reprioritize health and behavior changes. This crucial entry point is indicated by the red arrow above. So the ultimate goal would be to shift the diagram to one where the patient receives the services and resources they need to achieve long-term behavior change rather than having to reprioritize the behavior change. A major focus of trauma-informed care is helping patients become more resilient, and research shows that increasing resilience promotes positive behavior change. So resilience is often defined as one's ability to bounce back, but it really refers to one's ability to adapt in the face of hardships. These hardships vary and can be really diverse, but they include different tragedies, threats, stress, adversities, and trauma. One study outlines how 4 resilience factors should be considered when developing a trauma-informed care approach. And you will notice some similarity between these 4 factors and some of the SAMHSA principles. First, ensuring a safe environment for the people you serve is critical. All staff should understand common triggers and make conscious efforts to avoid them. This makes patients feel safe and prevents any re-traumatization. Organizations should also allow patients to feel like they have autonomy in the decision-making processes. You should encourage patients to have control over themselves and their surroundings. And this can include giving them options of, treatment steps or treatment plans and helping them make the decision for themselves. Next, patients are also making them aware will also help them in building resilience. Creating an awareness around trauma and how it connects to stress can help patients understand stress and their responses to stress. Teaching mindfulness techniques such as body scanning, rhythmic breathing, and even journaling provides them with coping skills to use in times of stress and trauma. And finally, trusting relationships between the patients and providers, as well as creating trust in the healthcare system as a whole, helps influence behavior change and creates better patient outcomes while also fostering a safe space for patients. And now that we've talked extensively about ACEs and trauma-informed care, I wanted to remind you of the Jamboard activity you completed during the masterclass. As a group, you gave great examples about how to integrate ACE knowledge into trauma-informed tobacco cessation services. And you may notice that some of the themes fall under the SAMHSA assumptions and principles for trauma-informed care. The first are realizing the widespread impact of trauma is demonstrated in the themes of awareness and education, comprehensive healthcare, and provider mindset. In addition, providing patient support is a large umbrella that encompasses several of the 6 principles, including safety and peer support. And while this is a great start, I really wanted to expand upon how to create a trauma-informed tobacco cessation services for health disparity populations specifically. And before we go into that, I did just want to shift your focus to the theme of screening for ACEs. Some studies talk about screening for trauma before providing care and how it can be a helpful tool in determining a treatment plan. For example, ACE screening is particularly helpful when there is a specific intervention an organization offers to people with ACE scores above a certain level, or if an organization wants to tailor its referrals. However, research also shows that screening for ACEs is not necessary to build resilience and foster that positive behavior change we were talking about. So therefore, one very important idea about creating a trauma-informed tobacco cessation program is understanding that trauma does not need to be disclosed or treated. Simply providing patients with a safe, autonomous space to learn coping skills can be enough to build resilience and lead to positive behavior changes. Okay, and now there are 4 steps to providing trauma-informed care for tobacco cessation. First, you want to focus on increasing feelings of safety for the patient. You want to avoid any confrontational, authoritative, or direct approaches. Meet them where they are. Next, you want to build support with and for the patient. In addition, increasing patient knowledge about tobacco use, stress, and coping skills is very important. Teaching coping skills, as well as how and when to use them, helps to build resilience. And it helps them create a plan for what to do when they experience stressors or triggers. And finally, think to offer alternative strategies for patients to grow, heal, and be well. This may include peer support groups or mindfulness training in the form of body scans, journaling, or rhythmic breathing. So let's now dive into an example of what a trauma-informed care approach would look like for an organization serving LGBTQ plus persons, for example. I will walk through each of the 4 steps of trauma-informed care for tobacco cessation and describe intentional and important considerations for each. So first, there are several ways to promote safety for LGBTQ plus patients. The organization should create and maintain a safe treatment environment. Treatment locations should be safe and affirming. Interpersonal interactions between staff and patients, as well as among staff, need to be inclusive, including the use of proper pronouns and gender identities. This will help the people you serve feel more welcomed and included and accepted in your organization. So this pours into the next consideration of overall inclusivity with the organization. So this also means building policies that are in place to promote diversity, equity, and inclusion, and to stop discrimination and stigma based on LGBTQ plus status. Next, building support for patients means the staff is very well trained and welcoming to LGBTQ plus persons. The Gay and Lesbian Medical Association, or GLMA, is a great resource to locate LGBTQ plus welcoming providers. In addition, staff must also be supported by the organization as a whole to do their work well. This could mean giving providers a little bit of leeway or flexibility in developing patient-specific treatment plans. Peer support is also key. This can be present in the context of peer providers, which we have another great webinar from this masterclass on, and they really help patients during the treatment course. Or the organization may also create LGBTQ plus specific treatment groups to increase comfort, trust, and mutual support among patients. And this can also help create more of a social network for people as well, that could help them through the cessation process. Next, knowledge building also occurs across staff and patients. It's important for patients to become aware of their stressors, learn how they can be tied to trauma, and know how they currently respond to these stressors. In addition, to build resiliency, coping skills, knowledge should also be taught. This may include journaling about the stressor and how to address it, exercising or participating in a hobby, or distancing themselves from a source of stress, for example. Finally, providers and staff must be trained on inclusive, safe, and affirming practices while also gaining awareness of LGBTQ plus specific issues and their barriers to tobacco cessation. And this will give the staff and providers a much better understanding of that population and will ultimately help them in serving them well. Finally, alternative strategies to tobacco cessation should be explored in conjunction with traditional methods, such as nicotine replacement therapies. It is important to give patients autonomy by explaining options for treatment and resilience building and allowing them to choose which strategy best suits them. Examples of alternative strategies may include establishing and maintaining a mindfulness practice to cope, or an online tobacco cessation programming, such as the LGBTQ plus specific program. This is free, or This Free Life, which was provided by smokefree.gov. And this increases access to population-specific cessation services. So by employing an approach similar to what I have outlined here, organizations can reach more people from health disparity populations, provide culturally competent and targeted smoking cessation services, reduce barriers to treatment, and improve cessation outcomes overall. And as a final practical step to help you get started in creating a trauma-informed tobacco cessation program, I highly recommend that you download the Behavioral Health and Wellness Program's free resources on tobacco cessation on our website, bhwellness.org. The Dimensions Tobacco-Free Toolkit for Healthcare Providers educates healthcare providers on tobacco use, teaches skills for engaging in tobacco cessation discussions, explains efficient methods for assessing an individual's readiness to quit, and gives information and research on treatments. In addition, it also has supplemental toolkits for several priority populations with information about those populations and population-specific considerations to take into account. And in addition, the Dimensions Tobacco-Free Policy Toolkit contains evidence-based information and effective step-by-step instructions to plan, design, implement, and evaluate a facility or agency-wide tobacco-free policy. Both are very extensive and can provide more details for how to launch tobacco cessations in your organization. So in closing, I hope this webinar was helpful, and I hope that it inspired you to begin thinking about how a trauma-informed care approach can help your organization develop a plan to increase tobacco cessation among health disparity populations in your community. And if you have additional questions, please contact us by phone or email. And on behalf of the entire Behavioral Health and Wellness Program team, thank you for attending today's webinar. And I wish you luck in developing your trauma-informed care programs in your organization.